Hi, my name is Erin Smith. I'm a nurse practitioner student at Auburn University. Today I will be discussing suturing. So the first thing that you're going to want to do as a nurse practitioner when a patient presents with a laceration is you're going to want to know when that laceration occurred, because typically you're not going to close a laceration if it's been longer than 12 hours due to the increased risk of infection. Once you've determined it's been less than 12 hours, you're going to want to know how this occurred. Mostly because you want to know if there's any risk for foreign body. Could there be glass or metal or wood? And if so, you're going to want to assess that. You may want to have to do an x-ray to see if there's anything in the wound, and then plan accordingly. You're also going to want to evaluate the wound. You're going to want to know how deep it is, how big it is. You're going to want to assess the edges. Are they clean edges? Are they jagged? And you're going to want to know if there's at least the possibility of a fracture underneath. If there is, that could be a surgical closure instead. If it is, if there's tendon involvement, that's probably going to need to go to surgery. Be careful of the ones in the face, especially around the lips, really around the eyes or the eyelids. And the ears, they really may need plastics, and may not be a candidate for closure in the primary care setting. You're also going to want to assess allergies, especially allergies to betadine, latex, or lidocaine, and then assess their tetanus status, especially if they haven't had one in the last 5 to 10 years. You're probably going to want to update that for them. Once you've decided that the patient is a candidate for sutures, that they don't need gluing or stapling, that might be more appropriate, then you're going to move on to cleaning the wound. Typically, it's cleaned with betadine or Hibiclens that can be diluted. And then you're going to want to irrigate. That way you can get any little bit of debris. That way you can get any anything that you might not see. That can be done with normal saline. And sometimes, depending on the wound, you may want to numb them first in order to be able to get in there and properly debride it. Sometimes patients just can't handle you debriding, especially a dirty wound. Sometimes they're going to need that anesthetic in. And then in order to anesthetize, you're going to use typically lidocaine. It comes in 1%, 2% with or without epinephrine. Epinephrine is great, especially if it is there's a lot of blood involved in the wound, because it will slow down that blood flow. However, epinephrine is not for use in ears, nose, fingers, toes, or genitalia, as it can cause tissue damage. So once you have got all of your stuff, then you can decide what type of suture you're going to use. Typically in the primary care or urgent care setting, you're going to use a nylon or an ethylene, which is most commonly used for those simple interrupted sutures, which is what I'll be demonstrating today. There are dissolvable ones that are typically used in the mouth or mucosal areas. That way they don't have to come back and have them removed. There are braided and some other ones that are typically not used in the primary care setting. As far as choosing your size, the most commons are going to be the 3/0 to 6/0. The larger the number, the thinner the thread. And it's really going to depend on where the wound is. So for the face, you're going to use a 5/0 or a 6/0. For the scalp and extremities, typically a 4/0 or 5/0. And then for the trunk or high tension areas, you're going to want to use a 3/0 or a 4/0. So today we'll be doing a simple interrupted suture with a 4/0 nylon. So once you have your wound cleaned, you'll want to use your lidocaine. So in order to infiltrate, and what infiltrating is basically you're flooding the surrounding tissues with the lidocaine in order to numb it, to reach that anesthetizing effect. So what you'll do is you'll take syringe, and you can either go inside or approach from the outside, and you're going to put your needle in and push the medicine in as you pull out. And you'll want to do that all the way around the wound, and you're going to want to follow that line that you've already infiltrated with. So if you've infiltrated this way, come back here and go kind of where it would already start to be numb, and then go all the way around. And you're going to want to give that maybe a minute or two so the lidocaine can reach its full effect. And you can check that by lightly touching the skin around the wound with your needle. They might feel pressure, but they should not feel pain. Okay. So then when you're ready to start, you will create your sterile field, because this will be a sterile procedure. So using your sterile drapes, create your sterile field. You will don sterile gloves and use sterile instruments, which of course I will not be using today. So you will get your needle drivers and you will pick up your needle like so. And then you're going to want to start 1 centimeter or 2 away from the wound. That way you can get some good tension on it. So you're going to start 1 centimeter or 2 away, and you're going to go in at 90 degrees and then move your wrist and come through the other side again, 1 to 2 centimeters away from the opening of the wound. You're going to pull it all the way through. And you're going to leave yourself a little tail so that you can tie your knots. Drop your needle off to the side onto your sterile field. You're going to go around twice, grab the end, and pull it taut. That is your surgeon's knot. Okay, that wrap it around twice and pull it tight. All right, so after that, you're about 4 or 5 times, you're going to go around once, and pull through. And you're going to want to do, so one time you're going to want to go over, the next time you're going to want to go under. So do that over, under about 4 or 5 times. And that's going to strengthen your knot. And then finally secure it. All right, so once you've done that, you'll want to grab your scissors and you want to cut it off. And I always try to leave enough of a tail on there that you can grab it later when you go to remove it. Because if you cut them too short, especially if they have a little bit of swelling afterwards, or if there's any like skin overgrowth at all, it's almost impossible to pick them up and pull them out. All right, and I also like to pull my knots to one side. And then we'll grab my needle again. And then we're gonna go, again, 90-degree angle. You wanna space it just, 5 to 10 millimeters to 1 centimeter apart. Push it on through. Get your tail, drop your needle, and wrap, pull, get that surgeon's knot, over, under, over, under, over. Pull it up, leave yourself a little tail, cut. So today we are going to be doing 5 of these. And again, you want your spacing to be pretty even. You want to start your suture at about the same spacing that you did on the other, 1 centimeter or 2 away. Go in at 90 degrees. Twisting your wrist, come out the other side. We're gonna pull through, get our tail, wrap, pull, over, under, over, under, over. And then cut. And then, like I said, I like my knots pulled over to one side. Okay, Same thing again. 90 degrees, centimeter or two away. Push through and try to keep your hands out of the way so that you don't accidentally poke yourself. Over twice, pull it through. Oop. Over. Under. Over. Under. Pull your knot to the side. Cut. And then the last one. Again, just that same technique. 90-degree angles, a centimeter or two away. Push it through. Sometimes you gotta nudge it on through a little bit. Oh, or accidentally pull it all the way through. Make sure you leave that tail. All right, over twice, pull it through, over, under, over, under, over. And again, do it 4 or 5 times. It secures that knot and locks it in place. Pull them to the side, cut. So hopefully it'll look something like that. You're gonna want these edges approximated, which basically just means that you want them to come together. So once you're done, you're gonna wanna go over some education with your patient. You're gonna wanna clean this up and you'll likely put a bandage on it. You're going to want the patient to keep it dry and covered for 24 hours. After that initial 24 hours, they can take it off. They can clean it briefly with some soap and water, pat it dry. Don't rub it. They'll do that once. You don't want it to snag. So pat it dry. They can do like a thin layer of, Neosporin or bacitracin, and they're just going to want to keep it clean and dry. If for some reason it's on a hand or arms, or they work somewhere that it can get very dirty, they're going to want to keep it covered and then change that bandage throughout the day. Again, just make sure that it stays clean and dry. And then they're going to have to come back to have that removed. For the face, it's going to be 3 to 5 days. For arms and scalp, it's going to be typically 7 to 10 days. For the trunk, sometimes on the legs, hands and feet, it's going to be 10 to 14 days. Typically no longer than 14 days, because the longer it stays in, the higher risk for infection. You're going to want to also educate your patient on signs and symptoms of infection, such as purulent, drainage, or pus, any redness, significant swelling, or streaking, any fever, or significant increase in pain. Then they're going to want to call you and let you know, or return to the clinic so that you can assess the wound. For the next 24 hours, they may have a little bit of light bleeding, which is perfectly normal even around the sutures, especially if this was a wound that had some significant bleeding. Tell them that's perfectly normal. Once it dries, they can just gently wash that away. Other than that, I think it's good. So thank you so much.